this concept of, if you're constantly working, you can't go to these CME courses, you can't go to these conferences to maintain that academic medical methodology and mindset and this evidence-based medicine correlations and stuff like that. And so I think you kind of get stuck in your ways of how you trained, and you never really change from that.
How's it going, everyone? And welcome back to the Adam Nessum Show. Super excited for another awesome guest. We have Dr. Iafrate, who is an assistant professor of rehabilitation and regenerative medicine and director of dance medicine at Columbia University Irving Medical Center. She was also named as New York Magazine's SuperDoctors Rising Star in Sports Medicine in 2019 and 2020, and is one of the team physicians for the U.S. ski and snowboard team. So thanks so much for coming on.
Thank you. Thanks for having me, Adam.
So it seems like even just from the intro, you're doing a lot of things. Can you talk a little bit about your path to getting where you are today within medicine?
Yeah, I mean, it was definitely a road less traveled, I'd say. I initially wasn't planning to go into medicine. I was planning to be an athletic trainer, actually. I was an athlete in college and got hurt a ton. So I was in like the PT office nonstop. And I'd always had like interest in kinesiology and human movement and, anatomy and biology and whatnot. And so, I don't know, after my third knee surgery, my athletic trainer was like, you should probably go into medicine. I feel like you know a lot about all this now. And then I was really interested. And this was back in Canada, which is where I was born, to Italian parents. And so, I decided I wanted to apply to medical school, but I thought I was tired. So I took a year off and moved to Kenya, and then did my supplementary application from Kenya, which I don't recommend doing because it was very hard with no internet.
That can definitely be challenging.
Yeah, it was tough. And then I ended up moving to the States for medical school, and I've been here since then. So I've been here 13 years now.
God. Did you apply both in Canadian schools and U.S. medical schools, or was there a specific reason that you ended up coming here?
Yeah, that's a good question. So I made a deal with my parents. I applied to MD schools in Canada and then DO schools in the States because we don't have DO schools in Canada. And my athletic trainer, again, told me about osteopathic medical schools. And for what I wanted to go into, I was thinking I wanted to do sports medicine, whether it was through orthopedics or PM&R, which is what I ended up doing. Right. He's like, going the DO route might be a good option for you because, it's very hands-on. If I was going into dermatology, I'm not sure I would have cared, but I was intrigued by the idea of it. And so I applied to DO schools in the States, 5 of them, and then a couple of MD schools in Canada. And I just said, wherever I like the best, that's where I'm going to go. And my family agreed to that deal. So I ended up picking the States.
That's awesome. And for those who, because we have a lot of pre-med listeners, not everyone knows the difference between DO, MD. Can you explain a little bit about like what osteopathic medicine is and some of the differences?
It's really about the philosophy. Honestly, I think that over the years, they've really started to merge a little bit more. And even the way that our board exams are going and the way that residency programs are going, they're becoming dual accredited. But basically, MD schools are allopathic medical schools and DO schools are osteopathic medical schools. They create full boarded physicians that can practice in every specialty that a physician practices in. It's just about kind of the philosophy behind how you learn that training. And then with DO schools, you do some additional training in OMM or OMT. It's osteopathic manual medicine. So learning some kind of hands-on techniques that can be really useful with like musculoskeletal care. I know a lot of OB-GYNs that use it for a lot of their prenatal patients. I use it a ton on the field, which is where I find it really useful because it's not like I can go do surgery on the field or something like that. Right. So it's something that's really helpful in that situation. But yeah, it's all about kind of the philosophy about how you learn. DO schools claim to be a little bit more holistic, let's say, and I hate the term holistic because it sounds a little airy.
It's like
it's not like potions.
That's like the go-to word.
And I don't like that word. I choose not to use it. But it's more about using that interconnection with how much the one area of the body can affect the other area of the body. So, that song you learned, like the knee bone's connected to the thigh bone and all that stuff. It's kind of that mentality with all of the body, right? But I think a lot of allopathic or MD schools are going down that route anyway. So I really see them merging quite a bit now. But
it does seem like these days it's more merged when residencies are combining, and so
exactly. So I wonder if maybe we're just all going to turn into MDOs or something like that.
Yeah, I guess we'll have to see what happens. And it seems like, I wonder if they'll start teaching. I know some schools will do like OMM training at MD programs now. Because I would say one thing you guys probably get from DO schools is more just musculoskeletal.
And our anatomy knowledge is I think superior when we finish medical school. Now you guys catch up to us during residency, I'd say, but just leaving medical school, I think our anatomy knowledge is just a little bit better because we spend so much time hands-on. Those palpation skills come into account.
Yeah, that definitely makes sense. Definitely like certain physical exam stuff, which is all the OMM that we don't do.
Right, exactly. Yeah, exactly.
What I tell students when I do advising is, especially at this point, because there's so many similarities now with the way that residencies are essentially the same and are merging, is just apply to both, and because you're just, in general, your chances will be better for acceptance.
Right. And find the place that suits you better. It doesn't matter whether it's MD or DO, just find the place that you like better, where you feel like you're going to learn the best. I mean, that's what I chose to do, and it worked out great for me,
And did you, when you entered medical school, I know you said you knew for sure, or you were pretty certain on sports medicine. How did you determine and I'm kind of asking selfishly too, because these are two of the specialties I'm in between right now, which is orthopedics and PM&R. How did you eventually make that determination?
So a couple things. I loved both of them, but I really like talking to people. And I found that in ortho, unless you do a ton of clinic time, which not a lot of orthopedic surgeons do, you kind of lose out on that talking and thinking through the puzzles. They're kind of like, this one issue is the problem. I need to fix it. Otherwise, I'm going to send you to someone else. You know what I mean? And I like the idea of the interconnections, right? I did kinesiology as my undergrad, I think in biomechanics. Like I love the anatomy and how those things merge together. And so for me, PM&R or physiatry kind of blended that a little bit better for me. And I love procedures, but I love like 30-minute procedures because I get super hangry in the OR. Like spine surgery, not for me. So boring to me.
8 to 10 hours surgeries.
I get tired. I get too hot. Like my head, my hair's too warm. It's like a scarf. So that was part of it as well. And a physiatrist had actually treated me for a lot of my injuries.
Interesting.
I was playing soccer in college, and I was like, this dude's job is cool. Like, I kind of like that. And, I was interested in doing spinal cord injury research. And so obviously PM&R does a lot of that too. So it was a good blend for me. People definitely say I have a bit of an ortho mentality. I'm a very intense person, but I think a lot of PM&R people can be too. We're all kind of the athletic type population.
Yeah, it makes sense.
Yeah. And I just, like I said before, like you're not doing surgery on the field, right? And so for me, covering, like having that on-field skill set, to me, didn't make sense to go into orthopedics. It made more sense to go into PM&R because I felt like I had more of a better concussion management, better spinal cord injury management, just because of what my residency gave me in terms of training. So
right.
Personal opinion.
It makes a lot of sense. What did you do to your knees?
Oh my, what didn't I do? It was all the right knee. The first one, I tore my ACL. The second one, I tore my medial meniscus and my plica. And my third one, I actually fractured part of my tibia. So this little plateau of my tibia that my ACL was like holding on to, I fractured that. So
I think you might have me beat. I just tore my right ACL and my left. So
nice. Balance it out at least.
Yeah. The left one got jealous, so
yeah, exactly. You got to play catch up.
I did it like right before step one, actually, so that wasn't too fun. But yeah, so you obviously do some game coverage. What's your like day to day? Because it seems like as an attending, you're doing so many different things. What's your day to day like?
Yeah,
as a attending PM&R physician.
Yeah, so it really depends. So right now, especially because of COVID, we're not doing that much coverage. And I actually, when I started at Columbia, I took a little bit of a step back from coverage. So I was doing a ton of sports coverage at Iowa, which is where I did my fellowship, which we can get into. But lots of D1 college sports. And then at Columbia, I've done a little bit of coverage, but I really wanted to build up the dance medicine part of my practice and just build up my practice in general. When you come in as a new attending, you have to get patients. So doing on-field coverage kind of took away from that a little bit. And so I do some of that. I help out with it. And that makes for very long weekends and, you know, some training rooms and whatnot. But I really wanted to build up the dance medicine component because Columbia didn't have that when I started here. And so that was kind of my big thing.
So are you fully academic then, or is it like or is it at all private where you're building up your own practice and getting patients like you were saying?
No, it's fully academic. However, you know, with the way Columbia's model is you get paid a salary and then you get productivity
Got it. Yeah.
On top of that, right? So RVU based,
stuff,
which who knew about RVUs before I started?
Right.
But they should really teach you that in medical school.
There's a lot of things
so
that should probably teach in medical school.
But yeah, so because of that, and you know, figuring out what the patient population I like taking care of the best is, and so you know, because I'm a big proceduralist, I do a lot of ultrasound guided injections and diagnostics and stuff like that. I get a lot of people referring to me. And so in order to get those referrals of those patients that I really enjoy seeing with all these weird nerve problems, and like I have to be MacGyver, which I really enjoy doing, you have to make yourself well known. So that's kind of what I've been building up in the last 3 years.
Makes sense. So what type of injections are you doing?
So I do PRP, prolotherapy, obviously corticosteroid injections very infrequently. And that's mostly for, you know, older people with arthritis that just need to get through life kind of thing.
Right.
I don't recommend it in my younger population. I do a lot of nerve hydrodissections and nerve blocks for a lot of our peripheral nerve surgeons to help locate like the area of a nerve being entrapped so that they can go in and surgically move that. I do a procedure called 10X or a percutaneous ultrasonic tenotomy, which is for chronic tendon injuries. And so I can go in and kind of do like a tendon scraping basically, but instead of, you know, having to fillet open the limb, I get to make a tiny little incision with a scalpel, use the ultrasound to guide where I'm going and actually cut out that damaged tissue using this, this device. It's called a microtip. So it's been pretty cool to be able to do some of these things and offer them.
Seems like all very cutting edge stuff.
Yeah, I think so. I think a lot of what I do is somewhat rare, which is cool. It's just where I was trained at Mayo Clinic and then at Iowa, and so I trained under some of the best people in MSK ultrasound, and so I think it's made me made me even better at my job. For sure.
That's great. What did you feel like you got the most ultrasound training during fellowship or like during residency as well?
I mean, residency's 4 years, fellowship's 1, right? So, but the crux of my ultrasound training happened in residency. Like if I didn't have the backbone that I got out of residency, I wouldn't have been able to keep up in fellowship the way that Dr. Mederick Hall was teaching me. My co-fellow at Iowa was actually a primary care, so he was family medicine trained, and his ultrasound skills were nowhere near where mine were, which is to be expected. Yeah. And that wasn't going to be a huge part of his practice. He just wanted to learn it to do a couple simple injections and that's it. But I do a ton of diagnostic work to look at, different parts of the body. So it's been really helpful to kind of expand on that knowledge during fellowship.
Gotcha. And correct me if I'm wrong, for like, especially for listeners that are confused on kind of how the whole residency and then fellowship for sports medicine works. You can do sports medicine out of a lot of different specialties. So you can be PM&R, you can start family medicine and then do a sports medicine fellowship. I think pediatrics. I feel like I'm definitely missing 2 other emergency medicine.
And IM, internal medicine, which internal medicine is probably the most rare. But you do see it. And so they do a 3-year internal medicine residency and then I think 1-year sports medicine fellowship. And then out of all the residents, so ERs, I think 3 years or 4 years, some of them. Family medicine's 3 years, PM&R is 4 years. And then the fellowship's usually 1 year, except for peds. So theirs is a 3-year residency and then a 2-year fellowship for sports.
Gotcha. And those are usually going to be like sports fellowships that are specific for peds residents so they make it 2 years. Makes sense.
Yeah.
Do you generally work with more adults or? Okay.
I see a good mix, I'd say. I see probably more adults, but I'm probably like 60-40. The college kids makes for, the young adult age
Right.
group
Yeah,
or whatever. But I see a lot of high school kids. The youngest I see is about 5. There's not a lot of sports injuries for younger than 5.
Unless they're really starting soccer early.
Hercules or something. But I get a couple sweet, like little gymnasts or karate kids that show up in my office. And those are fun for me because they're hilarious and very, very determined children.
I'm sure.
Yeah.
And how was the transition? How long have you been attending for?
3 years now.
Okay. How is that transition going from like a long residency fellowship to then now being finally like a fully practicing doctor?
Yeah, it's kind of scary and kind of exciting at the same time. Your first year, you go in thinking like, all right, I got this. I got great training. I am ready for this. Like, bring it on. And then after your first year, you're like, wow, I really don't know a lot of stuff still. And it's kind of one of those sayings of you don't know what you don't know. So you end up, making not mistakes necessarily, but things that you're like, oh, I could have managed that better. Or you end up still wanting to, check in with one of your older colleagues just to be like, would you still do this? Because that's stuff you got to do in fellowship and residency. You run it by somebody who is smarter than you or higher up than you. And so one of my biggest things that I recommend, if you can do this, is go do your first job somewhere where you have somebody who you think can mentor you a little bit.
Right.
And it doesn't have to be like them sitting right beside you, but just having somebody that you trust, that that you see as a mentor, even from far away, like Chris Visco, who's, the fellowship director here at Columbia for our sports medicine fellowship. He was one of my mentors. I'd never trained under him, but he was one of my mentors kind of from afar. I knew him fairly well. And so when he asked me if I wanted a job at Columbia, I was like, this is a perfect opportunity because I have him as, a source to use to just make sure that I'm doing things the right way. And it really helped me build up my skills and make me a lot more comfortable. And now I feel obviously much more comfortable. I'd say 3 years is when you start to feel like
finally.
Yeah, I know.
All right,
things
we
now.
got this.
Yeah.
It's funny how like you train forever and yet still there's always so much more to learn.
Yeah, definitely. So it's been better. It's been really good.
I was going to say, because that might be like one of the, especially for someone deciding potentially whether they're going to do academics or private practice, and especially if you're going to start your own practice, like not potentially having a mentor, because in academics, I would assume you usually have like someone higher up that, exactly.
Yeah. Yeah. And I think that's one of the big things that that really pushed me away from private practice is that you have nobody to turn to. And you don't, in private practice, it's kind of you eat what you kill. And so that sounds terrible talking about medicine, but you know what I mean? Like it's this concept
a term for like, just like how you're compensated.
Yeah, exactly.
not the actual patient.
Yeah, no killing and no eating. But this concept of, if you're constantly working, you can't go to these CME courses. You can't go to these conferences to maintain that academic medical methodology and mindset and this evidence-based medicine correlations and stuff like that. And so I think you kind of get stuck in your ways of how you trained and you never really change from that. And I think that can be dangerous. And that's why I personally would never go into private practice to start with, at least, because I think you need that pick me up a little bit.
That makes sense. Or if you do, I wonder if there's any way to like still have a foot in academics. Do you know of like people that somehow have?
There's a lot. A lot of them had to kind of carve their own path, though.
Right,
Definitely,
that makes sense.
Some of them are a little older that are doing that, or they're in private practice, but the private practice group has some sort of association with a hospital system, and that seems to work really well too. So some of these hybrid kind of models.
And that seems like more prevalent now with like big health systems kind of taking over everything.
Yeah, exactly. The umbrella for sure. Yeah.
So what would your advice be to, I guess I would be the target audience for this question, but like a medical student, maybe even pre-med that's potentially interested in going into PM&R?
I mean, learn what it is, learn everything about it. PM&R is kind of a fairly broad specialty when it comes right down to it, because even though it's very musculoskeletal based, we definitely have like our fingers into, ortho, rheumatology and neurology kind of, and then like blend all three of those into this PM&R kind of mentality. I think shadowing a physiatrist would be a really good idea. And then figuring out what part of PM&R you're really interested in, because there's definitely some residency programs that are very strong in outpatient PM&R, which is more your pain medicine, your sports medicine, some of your pediatrics, and some of that like kind of long-term or acute injury stuff. But then the inside part of it, the inpatient part, there's other hospitals that excel in that and maybe don't have as strong of an outpatient thing. And that's more of your, inpatient spinal cord injury, inpatient stroke, inpatient pediatrics, things like that, with a lot of genetic disorders. So kind of figuring out which way you might want to go on that path, because a lot of these programs are definitely stronger in one than they are in the other, in my opinion anyways. So that would definitely be something that I'd suggest doing for sure.
No, that makes sense. It's one of the cool things about PM&R, at least to me, is how broad of a specialty it really is. You wouldn't think of it like that.
No.
Even if you know what it is to begin with, because I feel like it's not one of the well-known, like experience I'm getting is like, I'm having to go out of my way to find it now.
Absolutely.
Because it wasn't like really mentioned in first 2 years of medical school.
Yep. It was, they used to say it was like the best kept secret in medicine, I think. And I think it's becoming much more popular now.
It definitely is. Yeah.
Yeah. And people are seeing like, oh, this is a, good lifestyle and still really cool medicine and lots of procedures that you can do from it, but, and lots of fellowships that you can go into from it too, which is cool. But I think that, definitely like starting a PM&R interest group, trying to find a doctor that might be able to kind of mentor you, even if they're not part of your medical school, but somebody from, kind of far away. I have a couple of medical students that I'm mentoring, and I've never actually met them in person, especially now with COVID.
Was that through like social media or?
Yeah, some of them reached out to me through social media. Some of them we did a actual dance medicine research project together.
Yeah, research is always a good way to get the foot in the door.
Yeah, come to a doc and say, hey, I have an idea. And that's a really good way to make us realize that you are truly interested, because it's a waste of our time if you're going to say like, oh, I'm kind of interested, but not really. And like just testing and like putting my foot in the door. This year, it's not really possible, but other years you can do observerships for like 2 weeks. I take people all the time from random medical schools, not necessarily just Columbia.
Do you do that? Do you do that as an elective type? Like they're on like an elective in their fourth year. But
I've even had residents from like already in PM&R residency come do an observership or an elective with me specifically, just to see about like the fellowship program, because our sports medicine fellow spends quite a bit of time with me.
Gotcha.
And so they'll even do that, and I'm happy to do it because I know that they're truly interested.
I might be sending you an email at some point.
That's what this year, not a good year.
No, I know. That's what I feel bad for like a lot of the pre-med students I mentor is there, because holding with medical school applications, like you need to get shadowing and clinical experience. And it's been so difficult this year.
Hard. Yeah. Even for the fellowship interviews, I think some of them are like, oh, it's been great because it's cheap because I don't got to fly anywhere. But you lose something, that vibe of, actually meeting somebody in person.
Everything's just online interviews now.
So
do you do that? Are you part of that process for bringing up for the fellows?
Yeah. So the fellows and actually the residency program, I do their interviews as well. But we take 2 fellows at Columbia, Cornell, because we're both under the NYP umbrella. And so we have one fellow that's kind of Columbia, Cornell, and then the other fellow's Cornell, Queens. So I definitely hang out with the one that's at Columbia, Cornell much more often. But I know them both, and I train both of them, and we do a lot of ultrasound together. And one of them hangs out with me in clinic twice a week. So she spends a lot of time with me.
And then the residency is a Cornell Columbia residency, right?
Yes. Yeah. So at our hospital, that's not the case, obviously, at most places. You are just one hospital, but at NYP, it's dual campus, which is a lot of traveling for the residents, but they manage it very, very well. And so it's kind of cool.
Both in Manhattan, so it's like not as
bad. It's not that bad, and subways are easy, but so they kind of spend some time with me. So I'll usually have them for, a couple of weeks per block, and then it'll switch out. So I don't have any of them for a very long period of time. It's maybe a month each or 6 weeks or something like that for a day or two. But the fellows are with me kind of all year long.
Got it. That makes sense. I guess like for residents, there's so many different subspecialties to see and rotate through within PM&R.
Yeah. So, but we have, even for our third and fourth years, we have elective time that they can use and spend like a full month with me if they want to. It's just, I travel a lot between clinics, right? I have 4 different clinics that I go between. Yeah. So right now I'm only running 3 of them because one of them is at Columbia, the university. And obviously there's no students there right now. So I'm like, why would I have this? So
how did it wind up that you're doing 3 different clinics?
So part of it was me asking to do that because the patient populations are so different in different areas of New York. Part of it was just kind of finding, space that I thought would be good for me. And part of it, at our main campus, that's where I teach a lot of the residents, and that's where I do a lot of the resident teaching and didactics and whatnot. But then in Midtown, that's where I do a lot of my procedures. And so, and it's a very busy clinic, but it's also a little bit younger population. And then I also go all the way up to Scarsdale, which is pretty far north. But I see a lot of pediatrics up there because there's families that live up there.
Right,
so
makes sense.
It gives me that nice blend of patient mix. And so right now I don't mind it, but it is a lot of travel.
Gotcha. So when you're not busy covering teams and working 3 clinics, what are you doing for fun?
I normally travel a ton.
Right.
That is my thing. But this year has been rough. I actually did go to the Maldives a couple of weeks ago for my birthday.
Oh, nice.
Which was very nice.
Happy birthday.
Thank you. Appreciate it. It was one of those like, okay, I got to make this work. And Maldives is actually pretty cool. They make you test before you go on the plane, and you test before you leave the Maldives as well to make sure that you're negative before you're allowed to fly, which I think is a good idea.
I agree.
Yeah. And then I'm a big skier, big dancer, big rock climber, like to work out a lot, and, just spend time with friends, preferably in person, obviously.
Yes, always better, but these days, sometimes have
do what
to
you got to do. Yeah. Thanksgiving was weird. And I just got my green card a couple months ago. So
nice.
Yeah. So this was actually my first Thanksgiving in America where I felt like it was like my Thanksgiving.
Right. Now you're celebrating it.
Yeah. So that was kind of nice.
Awesome. Yeah. And then any future goals with what you want to do in your career in terms of practice wise?
Oh yeah. I'm not even close to done. So becoming the director of dance medicine was big. That was kind of part of my goal. And so we're building up this performing arts center, which I'm excited about. And it's going to take a couple of years, I think, to really truly build up into what we want it to be. But I'm excited for that. And I would love to become the fellowship director eventually. Not saying Visco's going anywhere anytime soon, but I would like that to be kind of that's the goal I have for myself. I prefer to stay in academics. I like it. I like teaching a lot. But I think fellowship director would be a really fun gig for me for sure. And I do want to get back into working either professional sports or high level D1 college sports. At some point, it's just, like I said, I think I gave myself 3 to 5 years to build up my name, keep lecture. Like right now I get asked to lecture nationally, internationally, obviously regionally as well, and virtually now. And that's been really great, but I want to keep kind of building up that name. I want to do a little bit more travel with the ski team because I absolutely adore doing that. So definitely hands in lots of pots, but
definitely a lot. Is there a specific sport when you get to that, either professional or high level college, that you like doing more than others?
I mean, I love football coverage. I have a really great time on the field. I just really enjoy football. Shout out to Sarah Fuller, by the way, that Vandy.
Yes, very cool.
It wasn't a good game, but that was really cool to see. But otherwise, I also really like basketball. I like covering basketball games. It's nice because it's always not terrible weather because you're indoors.
Basketball is always
that's kind of a sweet treat.
I played soccer and basketball growing up, and my mom, she always preferred going to basketball games. So.
Yeah, of course, right? Yeah, dream job. If we were just talking, what's your dream job, Iafrate? I'd say team doctor for AC Milan. soccer.
Right. All right. Hey, you never know.
So
You never know. Awesome.
Familia. So maybe I'll be moving back to Italy at some point, but not anytime soon. So.
All right. Well, I'll keep an eye out, watching your progress from afar.
Thank you.
Awesome. All right. Well, thank you so much for coming on. I thought this was great. I think a lot of students or people, especially people interested in PM&R, are going to get a lot of value.
Good. I hope so.
And yeah, just thanks again. Really
You're
helpful.
welcome.
Also helpful for me because obviously I'm interested in
Yes.
PM&R.
Yeah.
All right.